Welcome everyone. I'll just give everyone a couple of seconds to start streaming in. And for those just joining, just a note to say that we will be recording tonight's session. All right then, well, good evening everyone. On behalf of Eastern Melbourne Primary Health Network and Banksia Palliative Care, we wish to welcome you to the final series of our 5-part webinar. My name is Sonia Mbezi and I'm the Palliative Care Program Facilitator for, here at Eastern Melbourne Primary Health Network, and I was previously working as a physiotherapist in palliative care for the last 12 years. Now, before we begin, I'd like to start with an acknowledgement of country. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nation whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. EMPHN is committed to the healing of country, working towards equity and health outcomes, and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience and their supporters and the practitioners who work with them and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Just some quick housekeeping for today. All attendees will remain on mute throughout the presentation, and please type any questions for our speakers in the Q&A box at the bottom of the screen, and these will be answered throughout tonight's session. So before we begin, just a little bit about the PHNs and who is Eastern Melbourne Primary Health Network. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially the most vulnerable. The PHNs achieve this by improving access to existing services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring they receive the right care in the right place at the right time. So tonight's event focuses on enhancing your expertise in the assessment and management of gastrointestinal symptoms within the community palliative care setting. This event will equip healthcare professionals with the knowledge and confidence needed to provide comprehensive care for patients experiencing symptoms such as constipation, nausea and vomiting, fatigue, diet changes, and bowel obstruction. And our introduction for our presenters for the evening. Dr. Chien is a palliative medicine specialist consultant serving various hospitals and community palliative care services in Victoria, including Banksia Palliative Care. On Saturdays, he also practices as a GP. His dedication is steadfast, focused on supporting individuals with progressive, incurable diseases to improve their quality of life, despite the challenges of illness and end-of-life care. Beyond his clinical responsibilities, Chien tirelessly works to enhance community care through both his clinical and administrative roles. Moreover, he actively engages in teaching and mentoring medical students and specialist trainees, fostering a culture of academic excellence and compassionate care across all clinical environments. Wendy is a registered nurse with over 30 years' experience and a significant amount of that time being spent in community palliative care. She is currently the training and development consultant at Banksia, responsible for internal and community education. Wendy is passionate about best possible palliative care outcomes for people living with a life-limiting illness. And Crystal. Crystal has been a registered nurse for over 20 years with 15 years experience as a nurse immuniser. Her passion lies in public and community health education and communicable diseases. Crystal has had an extensive amount of experience throughout her career with diverse roles from aged care, ward nursing, international humanitarian aid, working in the COVID-19 workforce, and now her current role as a Healthways program specialist with Eastern Melbourne Primary Health Network. So they are our wonderful presenters. And now I'm actually going to hand over to Crystal, who's going to give you a little bit about information about how health pathways can assist you with regards to palliative care, and even more specifically, these symptoms that we're talking about tonight. So thank you, Crystal.
Thank you very much, Sonia. Let me just get my screen up.
Perfect.
Thank you very much. Hi, everyone. My name is Crystal Portobedo. Thank you very much, Sonia, for the introduction. I'm the health program specialist at Health Pathways Melbourne. I recognise that your time is precious, and especially with the informative webinar with Chien and Wendy on managing symptoms in palliative care about to begin. So I'm here to provide a brief introduction to Health Pathways Melbourne. My goal is to demonstrate how this platform can serve as an invaluable resource, enabling you to efficiently access pertinent information at the point of care with your patients. First, a little background. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will demonstrate how to access and navigate Health Pathways Melbourne to find relevant pathways on palliative care, specifically on symptom control this evening. Navigating Health Pathways. Visit the Health Pathways Melbourne website and log on. Here you can see the landing page. You can see the latest updates and recent pathway updates. You can search for the relevant pathway by using the table of contents on the left-hand side or the search bar located at the top of the page and enter relevant keywords like nausea. You'll find over 40 palliative care pathways. Today, we're going to be focusing on nausea and vomiting in palliative care. Firstly, as you come onto the page, you'll note that there's a clinical editor's note, which is a concise temporary edition offering succinct updates on broader health system developments. These notes serve as a valuable insight into current healthcare practices. As shown here with the palliative care access to core medicines, and the core medicines list. As we continue down the page, we'll get to the assessment section. This provides a concise list of steps that clinicians may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout the pathway provide supplementary information. Demonstrated here with associated symptoms and possible causes. As we navigate further down the page, we'll come to the management section, which provides a list of steps that users may consider taking and includes additional information to execute these steps and links to referral options. This section also provides links to relevant extended information the clinician may wish to consider. Shown here specifically with things like goals of care and links to things like advanced care planning. Consideration for non-pharmacological interventions. And here, GI causes. with additional information on drugs with links out to the AMA guides. So we continue down the page, we'll come to the referral section. This section includes locally relevant requests and referrals that the clinician may request from a third party for their patient. Demonstrated here with the palliative care advice, which is going to take us through to another page, and we'll go to the specialist care services. This page provides private and public services. And under public here, with Community Palliative Care, you'll find it's localised. And there's Banksia, just there, providing all the links out and the specific criteria required and the information required from the referrer. Returning to our original page, if we go down to the bottom of the page, we do have the information section. This information section provides a list of selective, useful information specific to the health professionals and patients. Thank you very much for your time, and I'm going to hand over to Chien.
Hello, can everyone see my slides now?
Perfect, Chien.
Great. So thank you again for attending and giving us this opportunity to talk to you guys about tonight's topic, management of nausea, vomiting, and other palliative care symptoms in the community, mostly focused on gastrointestinal tract. So we start with some acknowledgements, and from Banksia Palliative Care Service, Michelle Wood, our CEO, and Annie Lee, our engagement officer, very much integral to running of these sessions. Our colleagues at Eastern Palliative Care, so this is really a collaborative content creation, and also they run their own versions as well. And of course, Sonia and Nicole and other staff at the East Melbourne Primary Health Network, very much integral to hosting these sessions. And Sonia's here tonight with us, and also Northwestern Melbourne Primary Health Network also have help in these sessions as well. So we start with some take-home messages, and there are 5 today, and we'll go through each one of them as we go along a case. So a hypothetical case, however, based on real cases that I've had to manage before, sharing care with other GPs for someone who with these symptoms and care needs at home. So first one is constipation prevention with prescription laxatives is often required for patients living with life-limiting, threatening illnesses, especially in setting of regular opioids. Second one is select antiemetics based on underlying symptom mechanism and side effect profile. Third one is fatigue is multifactorial, often refractory, and energy conservation as well as equipment provision is crucial. Fourth one is that always maximize dietary protein and energy intake and potentially avoid fiber in a diet. And lastly, patients with risk of malignant bowel obstruction benefits from additional planning. Starting with the case. So Mrs. CH, she's a 79-year-old Vietnamese lady who came into your clinic with her son. She is non-English speaking, but her son speaks fluent English. And she's only been to the clinic once in the past for a repeat opioid prescription, seen by your previous registrar, who diligently updated her medical history of metastatic pancreatic cancer, gastroesophageal reflux disease, asthma, sciatica, type 2 diabetes, and dyslipidemia. She was advised by your registrar to have some cloxosena on hand at the time of the prescription repeat prescription of her opioids. And of course, this is quite common because people who have been diagnosed with cancer often have so many hospital appointments that, they haven't been back to the clinic that often. And all their appointments are being absorbed by the hospital. So after you started consultation, you worked out that they were told to come back and see you after an episode in the emergency department with nausea and vomiting. So the son had the printed copy of the preliminary discharge summary, which hopefully do arrive in your inbox eventually. And that describes nausea treated with intravenous metoclopramide, intravenous rehydration, and they did find fecal loading in the ED and treated with enema with 1 bowel motion prior to discharge. She was prescribed oral metoclopramide 10 milligram tablets and advised to buy oral Cloxone Senna tablets over the counter. Now, what else would you like to know? So with these scenarios, if you have any comments or questions or answers to these scenarios, please put it in the chat. And also we have Wendy here who will look at the chat and bring up any answers or comments that we haven't gone through, that I haven't gone through. And Wendy, please, if there's anything you want to add, just unmute yourself and add at any stage. So really, what we want to know is whether they're going to be adherent. So there's so many issues, especially symptom management and especially bowel management. It is a routine. So it is an ongoing care plan, ongoing situation that people need to learn to manage. So in fact, I often talk about constipation prevention because really it's what people need to learn in the new routines so fecal impaction doesn't happen again. And really isn't something we want to be catching up all the time because that will result in further emergency trips. So you worked out that Mrs. CH actually doesn't want to take her laxatives because and her son is ambivalent as well, and because she had diarrhea from Cloxone Senna in the past, because remember your registrar did provide her with laxatives already in the beginning. She was worried about malnutrition, does not want fecal urgency when she's going out, and doesn't think she needs to stool as she's not eating much anyways. How would you advise and what would you do for Mrs. CH and her son? So, of course, education and information sharing is the key. And those are very common themes about why people are worried about or don't think they need laxatives. The other thing is it's possible that she actually presented to ED with overflow diarrhea at the time, not that it was stated on summary perhaps. And that perhaps she just didn't realize her part of the diarrhea could be because she was impacted at the time. In terms of malnutrition, it's very important to work out what people are worried about. And as we know, laxatives do not cause malabsorption because laxatives mainly act in the lower gut. And in fact, if nothing comes out, nothing goes in. So to improve oral intake and improve her nausea, vomiting, it's actually very important to keep the gut functioning. In terms of the fecal urgency, that's actually the harder aspect of management and planning. Because it is true that if the stools are soft, people have reduced mobility, also reduced ability to hold in when they do have the urge to go. It becomes a bit of a planning process. And that's very real and limiting for people participating in activities of community activities of daily living. So one strategy is to advise trial of stooling every morning and see whether they do end up developing a more routine. And plus, if people do empty their bowels, it's less likely they will need to go again during the day. Another common explanation we need to provide is that there's the oral colic reflex that people often feel like they need to go to the toilet right after they eat. That links into the nutrition and absorption side as well. It's important to remind people that no, things doesn't just go through you immediately. That it's quite common for people to want to go to the toilet because they're eating something and the gut is trying to make space for the food. And that absolutely laxatives are very important to make sure they empty properly when they do. And that regular stooling actually allows more oral intake. So coming back to our first take-home message, which is constipation prevention with prescription laxatives is often required for patients living with life-limiting and threatening illnesses, especially in setting of regular opioids. And again, it's about learning how to use it. It's more than just having it on hand, but knowing there's a target as well. Now, we often talk about a target of one motion every 3 days, and that's to do perhaps more with our artificial definition of constipation being less than one stooling every 3 days. So often, if you look at the literature, you'll see, between 3 times a day to 3 times a week, and that's become a bit of a target when we prescribe a bowel routine, essentially. It's not that people can't have more or less, but it's important to remind people the target is we know they're not blocked, that they feel empty afterwards, and that they don't need to strain. So a bit of a reminder that there are many, many reasons that someone living with life-limiting illness can get into constipation. That the less you eat, the slower the gut is, that they are more likely to be constipated because we don't want them to block. That 1/3 of normal stool actually comes from the shedding of inside the bowels. So if they're not eating, people still can block. And in terms of treatment targets, look, a lot of people actually will say to you, well, they're used to going more than once a day, once every 3 days. They're happy to aim for once every day, which is absolutely fine. And some people will say, well, actually, they don't always go every 3 days. But the key is to remind them that, well, they have to go and that they have to feel empty and satisfactory afterwards. And we need to know that they're not blocked. Non-pharmacological strategies are extremely important. So other than planning, there's also the physical strategies. So we're talking the right posture. We touched a little bit about having a toileting routine in the morning. And there are some other sort of perhaps less evidence proven, but certainly helpful things and definitely not harmful things to do, like abdominal massage and keeping up with hydration where possible, and use a pair of prunes. Now, the big one often people ask about is dietary fiber. Is in setting of especially malignancy, but also with any terminal illnesses, any situation where gut transit is slowing down, fiber is a bulking agent and may not result in better motion without the hydration and the movement. So it may not be able to stimulate bowel movement like it would in a healthy gut where people haven't lost the gut muscles. So it can actually cause more impaction. And in setting of GI malignancies or anyone with risk of bowel obstruction, a bulking agent actually is detrimental. And in fact, a bowel obstruction diet would, or a diet to lower the risk of reobstruction actually involves actively avoiding dietary high fiber. So very important to explain to the person that it's a different routine nowadays. So picture saves 1,000 words. That is the correct position for defecation, in the sense that it allows relaxation of all muscles that's not required, and also free use of the abdominal muscles and gravity to help stooling to come out. So this is available in many resources. Pretty sure I pulled this from Better Health Channel.
Jen, can I just bump in there? I've got a couple of questions here about psyllium husks. If psyllium husks are useful, and also exercise and physical activity to help constipation.
Yes. So very good questions. Psyllium husk is a bulking agent, is a fiber supplement, which unfortunately can be dangerous in this population. So number one is people will need to have adequate hydration. So we're talking, liters of fluid, and often they already have a reduced oral intake, and they may have other reasons why they're more dehydrated as well. One is remembering organ failure means the fluids actually don't go to the right places, and they don't stay in the gut, essentially, because they already have a slowed down gut transit, and that doesn't necessarily mix with the fiber, and the fluid gets transported to other spaces very quickly. In terms of exercise, physical activity, yes, they do help. The question is whether they do allow or spare laxatives use, and unfortunately they don't. Many reasons in that people often are less active because they can't be active. They already have reduced amount of energy and strength, and there is a limit to prescribe exercise and physical activity in this population. And often we'll come to energy conservation as well in a second, but unfortunately it's quite limiting in terms of what's doable therapeutically in terms of physical activity for constipation. So really, we do rely on prescription laxatives quite a lot. Now, that's not to say, because there are some other agents, natural agents, prune lax being one of them, and prune juice and pear we'd mentioned before as well. Now, it's not because of fiber that they help, but because they do contain sorbitol, which is a natural kind of like lactulose laxative. Sorry, Wendy, were you going to say something?
No, I've just got a question here. Like, there is a question about an example of a bulk forming agent.
Yeah.
To provide.
So, yeah. So psyllium husk, or essentially, which there's many brands out there, Benny Fiber being one of them. So any of the fiber supplements are bulk forming agents.
Yeah.
I don't think there are other bulk forming agents that we use other than fiber ones. So all the other prescription laxatives, they are either softeners or stimulants, or some of them both, or osmotic ones doesn't quite describe whether it's a stimulant or softener, but rather it absorbs, that keeps the fluid in the gut or pulls the fluid into the gut. So it probably does a bit of both. I think there's another question, kiwi fruit, isn't it? Yeah.
Kiwi fruit, yeah, that's all.
Yeah, so the key is not to treat fiber or fruits outside of ones that we know definitely helps, which are prunes and pears, essentially. The others are all not as reliable. because they fibers, as we talked about, may be actually detrimental, and the others may not contain enough sorbitol or other sugars that non-digestible sugars that may help with the softening or defecating. So there is another. Oh yes, so it's important to make sure we diagnose and treat fecal impaction, because if they're already impacted, then it's very, very hard to disimpact that with oral laxatives, and generally some sort of suppository or enema is required. Opioid antagonists, sometimes you'll come across, and the commonest one probably being Targen, which contains oral naloxone mixed in with OxyContin, and the other one you may or may not have heard of is methyl naltrexone, which is a peripheral acting only opioid antagonist that comes in an injection. That's actually PBS as well. It's not a specialist prescribing. It can be prescribed by anyone. And the key to remember about them is they only help with opioid components. As we discussed, there are many reasons why someone's constipated or can get into constipation in this population, and opioids being only one of them. And in fact, if you look at the data for methyl naltrexone to be helpful, people need to be on a whopping 150 milligram oral morphine equivalent per day for methyl naltrexone to actually definitely make a difference. Not to say they're not useful to add, but again, it comes back to whether it spares learning of using other laxatives. No, it doesn't. And even if it does slightly, they still have to work out how much they need. So it really doesn't meaningfully result in a better routine or easier routine for a lot of people. Oops. So is there another question?
Yeah, there's just another question here about what about soluble fibre? You know, the Benefiber that you can get.
Yeah, so any fiber supplements are bulking agents.
That's a bulking agent, yeah.
So none of them are softeners or stimulants. So things like Cloxo, for example, and glycerol actually seeps into the stools or stool contents and make them softer. And things like Senna and Dulcolax, which is Bisacodo, the stimulants, they stimulate peristalsis directly. Microlax, Fleet, Picolax, they're sodium picosulfates. They draw fluid into the gut. Whereas, and lactulose as well. Lactulose is one of those undigestible sugars, but when it gets to the gut, it pulls in the fluid because it's not osmotically. And the fluid that gets pulled in then softens the stool and stimulates the gut. And Movicol or Macrogol, they're unique in that they don't pull in additional fluid into the gut, but they keep the fluid that it's mixed in. So the Movicol direction is you mix it with water, about 100 mils, and it keeps that 100 mils in the gut. So the body doesn't absorb that fluid that's mixed with Macrogol, and it makes it all the way to the large bowel and softens it. Now, whereas Benefiber, soluble fiber, or any fiber products are bulk forming agents, and how they work is that they actually make stools into clumps, and that stimulates peristalsis. Unfortunately, that only helps when the gut is strong enough to have meaningful or can, in a sense, upregulate its ability to push. So when it's too weak to push, then enlarging the bolus is not going to actually help the gut to push the stool out. So as opposed to a direct stimulant, so enlarging the bolus, if the gut is already weak, enlarging the bolus doesn't tell the gut to push harder. and the gut might not be able to push harder, and it results in blockage actually. Whereas the stimulant directly tells the gut to push harder. So that's where the difference is. So no, unfortunately, insoluble fiber is not helpful. It's generally not helpful in this population. So next scenario. So she was seen by one of our nurses at Banksia Palliative Care at home, and who helps visiting weekly to help monitor symptoms and reinforce use of laxatives. And her son has made another appointment with you on request from the nurse to get repeat prescription and review her nausea. Now, she's being advised to take regular Maxlon metoclopramide 3 times a day pre-meals, has run out of the script from emergency, and is now taking her leftover ondansetron 4 milligram 3 times a day instead. Her son says, I'm not sure the medication is working. What else would you like to find out? Is the question related? Is there a comment in the?
There is a question regarding to the posture being helpful for constipation, such as using the footstool to straighten the rectum. That was in your picture.
That's right.
Yeah.
Yeah, definitely.
It's actually, it's a very, we actually should all do that, to be honest.
Yeah. So
theoretically.
That's right. That's right. Essentially, how that works is it frees up the muscles in the abdomen, so that the muscles are not used for anything else when you're in that posture. Plus, you're in a position where gravity will help the stool to drop out as well. So essentially, that's how that posture works. And we did have a graph earlier in the presentation, and generally in terms of teaching the patient, demonstrate it to them yourself on your practice in the clinic, plus or minus giving them the picture is the best option. So in this case, where the question about antiemetics not working, for me, the first thing I want to find out is, what do they mean? Because the antiemetics stops the sensation of nausea, but they don't make anyone eat better. So it may be that, but plus it doesn't increase appetite. Plus, it may be that because they're too tired, and they're hoping that by taking these nausea, that their anti-nausea, the energy actually improves as well. So often working out what people are hoping the medication's working for is a very important first step. Is there another question in the chat?
Yeah, it is. Yes, there is just regarding, but I think it's coming up though. We're talking about the antiemetics, and ondansetron is constipating.
That's right. Yeah.
What is a least constipating antiemetic? But I think you're coming up to that, yeah.
That's right. That's right.
Yeah.
So having a bit of update that we find out she is having regular bowel motions now. There's no reports of vomiting or vertigo. There are no other localizing symptoms. There's the question of whether we would order investigations. If so, what would we order? And what would you advise or do for Mrs. CH and her son? So in terms of investigations, it comes back to what we often talk about, goals of care discussions, and that's a term that's been used loosely around many things, but especially ceilings of treatment or limitations of treatment. On the other hand, really it's trying to work out whether there are things that we would still treat in terms of our investigations. And things like hypercalcemia can certainly add to both constipation and nausea. And that may be something that we would check for, knowing that if she were to have it, and she will be open to go into hospital for that, for treatment. And it might not be something you would order if we already know she's not wanting to go to the hospital. The other things are imaging and see whether there are other reasons for nausea outside of the gut. And one is that might guide your selection of antiemetics, but also it may inform whether we might need to prepare or plan for other symptom managements and other prognosis issues. But again, it comes back to, as we talked about, we can select antiemetics based on its side effects as well.
Well, there is a question here about, just ask about the type of stool that could still be constipated. So I'm not sure what you mean by that.
Yeah, so there is the Bristol stool chart, of course, and
okay, I see what you mean.
yeah, I think if it's the type of stools they're asking, yeah, it is pictorial, and yeah, I sometimes do reference to it, but ultimately it's the report or the experience that that it's easy to pass and empty after that I find most useful.
Yeah.
Yes, softer stools on the chart are often useful to aim for especially people who have a more visual understanding, and that may be helpful for patient education. So in terms of metoclopramide, so I can see the comments here. So again, comes back to symptom management and trying to work out exactly what people are going for. So one catch point is nausea and vomiting don't always go together. We'll come across that a bit later as well. But especially things like delayed gastroemptying. Often people don't feel nauseous until they try to eat something and eat too much too quickly, and then they'll vomit it back out. The other common scenario, well, not common, but another typical, I should say, scenario is bowel obstruction, where we actually do manage, we do use different medications to manage the vomiting and nausea. And that, yeah, they may not be nauseous, but they're still vomiting things out, and we need to introduce anti-secretories more so than escalating the antiemetic. But also, as we've talked about, it may be oral intake or energy level they're worried about, and recognizing that none of these medications actually directly help with any of those. Saying that, though, metoclopramide do have prokinetic or gastric emptying effects. So it may mechanically allow people to eat a bit more during the meal when take a pre-meal. But important to remember, they don't make you hungry. So it helps more with early satiety and not really with appetite. And we'll talk about steroids as well. But those are the 6 syndromes that's been described with nausea and vomiting. And they all have essentially, we have medications that target some of them specifically, but in fact the evidence says empirical treatment. So it's not wrong to use ondansetron if we purely think about symptom mechanism, because mechanistic approach is not necessarily better than empirical approach based on our studies. On the other hand, it certainly is probably wrong to use ondansetron first line, because we know constipation is already a problem in this patient. So side effect profile probably practically inform our selection more than the mechanisms a lot of the time. Saying that, though, I think early satiety is quite a specific symptom, and arguably not exactly the same as nausea. So on the history, trying to work out what symptom they have and choosing them, there's still merits there. But if it's just generic nausea, then that's where we really start thinking about the side effects and which ones we need to avoid. So we know a lot of the Parkinson's ones we have to avoid dopamine antagonists, which covers most of our antiemetics. And yes, in terms of constipation, we do need to avoid ondansetron specifically. Saying that though, in fact, cyclizine slows down your gut too. So again, it's a bit of a mix. And if you have no choice, you manage the nausea and then manage the constipation. You may need to up-titrate your laxatives and see how we go.
There was a question there, Chien, about metoclopramide being contraindicated for people with Parkinson's disease.
That's right.
And the other options they could possibly use in regards to that.
Yeah, so that's a common question. And when they can take oral medications, you do have domperidone to use, as it doesn't cross the blood-brain barrier and doesn't exacerbate extrapyramidal side effects. On the other hand, if they can't, the injectables, you're really left with cyclizine and arguably ondansetron, saying that the ondansetron is also quite expensive compared to cyclizine. Even though cyclizine is SAS, ondansetron injectable is still more expensive. And it comes back to, if you really have no choice, then you manage the constipation with your laxatives and enemas, and you use the medication for nausea. So, and just like we wouldn't necessarily switch opioids or avoid opioids because of constipation, because it's impossible to actually use any opioids because they're all constipating. So yeah, cyclizine is expensive, but compared to ondansetron, it's less. At least injectable anyway. Of course, ondansetron do come in wafers. Saying that, cyclizine can be crushed too. So domperidone can be crushed too. So yeah, if they can tolerate oral stuff, crushed domperidone would be something I would recommend. So yeah, after you dig in a bit deeper and you realize, yeah, what they're worried about is that she's not eating, she's getting thinner, gets tired very quickly. She's just being starved to death. I don't understand why they wouldn't just put a feeding tube in her or put up a drip. How would your advice would do for Miss CH and her son? So it comes to our two other take-home messages, and that is that fatigue is multifactorial, often refractory, and energy conservation as well as equipment provision is crucial, and that always maximize dietary protein, energy intake, and potentially avoid fiber. So, and this is part of learning to live with a progressive illness, and it's generally applicable because we don't really have something that gives you more energy or makes you stronger. Comes back to the use of dexamethasone. In fact, we know it will worsen strength in the long run, and stimulants like dexamethasone and Ritalin we'd sometimes use, they really just wakes you up, or perhaps with dexamethasone it can make people eat a bit more, but does not result in overall functional improvement and often results in further deterioration if they stay on this for too long. So really it's learning to manage reduced amounts of energy, prioritize activities of daily living. And yeah, if people do want to exercise, they can, but remember to remind them that to save energy to eat and save energy to get around and shower. There are many other aspects of fatigue, that some of which may be modifiable, some which may not, but important to acknowledge all of them and check if we have a plan for all of them. And there's no clear-cut evidence on other things like progestin, fish oil, and NSAIDs, although they are used in cachexia clinics. And but probably the multidisciplinary approach in those specialized symptom clinics are what makes the difference. One thing to remind people is that in terms of reduction appetite, it is the result of deterioration, not the cause. So, and often that's what people are worried about, and certainly in a lot of the cultures, including my own, starvation is a terrible thing because it's of course associated with care or the lack of care. But that is not the case, and it is something we do need to remind people and explain to people that it's the body is not tolerating the intake. And in fact, if we have artificial nutrition or hydration, it generally is not effective. They go to the wrong space, and they can cause complications. One thing that's a bit more relevant in when people deteriorate to a stage where they can't swallow is that comfort feeding. So often you'll see hospitals or perhaps some other healthcare providers would say at-risk feeding, and that's actually, especially in nursing homes, can be a very confronting recommendation to carers. In fact, there are well-documented scenarios where carers don't want to take the risk. So it is important to remind people that comfort feeding is on the request of the patient to offer gentle assistance and not causing distress such as coughing and not related to volume intake. And also to remind the family that, yes, if the person's hungry and requesting, and they'll be reminded and offered assistance, gentle assistance. But if they're unconscious, if they're not able to wake up, and if they're not able to swallow, and support not to force it. But there's no formal restrictions. Saying that though, if they can swallow thickened fluid better than thin fluids, there's no reason not to make that available. Not to say if they want a cup of tea in a normal consistency that they can't, but it's not about restricting, but it is about making sure options are available.
There is just a question here. I know we're starting to run out of time, I think, but what about PR antiemetics?
Yeah, so again, that's not necessarily a problem. Saying that and it flows well into this as well, in that you do get a letter and phone call from the Banksia nurses a few weeks later requesting anticipatory prescriptions and orders for injectable medications at home. And the question really would be, why not use injections if the nurses are able to visit and help patients to use it when they can't take the medications? Mm. So yeah, certainly PR medications have a place if you have no other options. But also, if they can't take their oral formulations, there will be our top patients where our nurses will keep a close eye, and there's 24/7 nursing service for unplanned call-outs to come in and put in a subcutaneous intima and draw medications and help teach the person to use injectable medications. So that's probably a better care, whereas when it's available. So you found out she had another ED presentation with essentially malignant bowel obstruction. She refused nasogastric tube decompression and didn't want to stay. She came home against advice with instruction to return to ED if not managing. But of course, often hospitals don't have a clear plan of how to manage it at home. And because people think that people will come back to ED, and we learned through COVID that people don't. Don't always, anyway. So her nausea and vomiting have resolved since, and her son decided to make a telephone appointment with you, as it's too hard to come to the clinic now. How would you advise her or her son? What else would you like to know and do? So this is really a good time to notify Banksia. So the 24/7 number is available to everyone, all the service providers. So if you get called by the patient, please call us as well. And let's work out a plan together. patients with risk of malignant bowel obstruction benefits from additional planning, as we can imagine. And what managing at home is not straightforward, though we can go through what's available at home. Is there a comment I need to discuss immediately, or no?
No.
So yeah, so it's really the home stretch now, because yeah, this is something where I talk about shared care. So very much one of our physicians, specialists who does this every day, will also be involved in discussing what's available and how to manage it. Clearly, we're very dependent on injectable medications in bowel obstructions. Worth noting that up to a third of patients with colorectal cancer develop it, and outside of GI malignancies, ovarian, breast, and melanoma also commonly causes malignant bowel obstruction with metastasis into the peritoneum. So again, vomiting is more prominent in nausea. This is where people can say they vomit, but they don't feel nauseous until they do vomit. Abdominal distension, they may have pressure from distension. They may have ileus, but they may also still have peristalsis and pain triggered by peristalsis. They can also still stool, because if the obstruction is higher up, then the column may still stool, whatever's already in it, or shed more new ones. So acute management often involves whether we do buy people more time in terms of fluids. Nasogastric decompression is probably the most direct mechanical symptom management. Often people are kept nil by mouth because the thought is they may have surgical fix, or eating can cause more vomiting and cause more complications. But really is talking about, as they want to stay home, is it really helpful to try to implement these, especially malignant bowel obstruction can be a terminal event, and this might be the last chance to stay home. So we generally split the management medically into use of analgesia, use of antiemetic, use of spasmodics, and use of antisecretories. So analgesia, pretty straightforward. Anti-nausea, we talked about it already. Some people would actually push prokinesis until there is colicky pain. So it's not absolutely contraindicated, but certainly if it's worsening pain, we shouldn't push it. And antispasmodic helps with both pain and potentially is also antisecretory, as the commonest one we use is buscopan. Dexamethasone can actually improve the chance of resolution. There's a trend in the evidence that it might, but generally it's used for a few days. If there's no difference, we discontinue it. And yeah, you may need to source injectable dexamethasone for that. Fluids really purely for buying time, if that's what people wish, and it doesn't really help with any other symptoms. In fact, we know when the gut's not moving, the fluid probably goes straight into the gut because of the osmotic effect and comes back out in the mouth. So not really useful parenteral fluids. Laxatives, this is where PR may be better than oral. If they're blocked up top, then and they need some evacuation from the bottom, maybe. And GT, if preferred and tolerated. So she went on to have a visit from one of the Banksia doctors and rotated her opioids to fentanyl patch. She obstructed after a few weeks. We started a syringe driver with haloperidol buscopan. She did then decide to go to ED, have a nasogastric tube inserted, and then came back home. She was bedbound from this time on. Bed-based care was set up and provided by rostered family members. And buscopan was removed from syringe driver because of dry mouth, but reintroduced when there's a gastric tube accidentally pulled out. Was able to hold conversations until the last day and died 24 hours of becoming unconscious. So yeah, take-home messages. Constipation prevention with prescription laxatives is often required for these patients with life-limiting illnesses, especially setting regular opioids. Select antiemetics based on symptom mechanism and especially side effect profile. Fatigue is multifactorial, often refractory. Energy conservation as well as equipment provision is crucial. Always maximize dietary protein intake and potentially avoid fiber. And people with risk of malignant bowel obstruction needs additional planning. So very quickly, referring to Banksia, so you can go to our website. If you're outside of Banksia area, go to Palliative Victoria, and there's a find a service provider. You put in the patient's address, postcode, not the clinics. There are a few other palliative services around the state, but mostly one is they'll work closely with Community Palliative Care, but and also that mostly they're very short term or transitional. So yeah, again, find a service provider from Palliative Victoria. There is the PEPA program. So if you're interested to come and spend a day at Banksia and see exactly what we do to your patients, then yeah, that's the program to help fund that opportunity. And there's also research trials in palliative care still, mostly for symptom management. But if your patient's interested in trialing medicinal cannabis with more monitoring and outcome tracking, and also, or maybe seeing for breathlessness, then please contact our team. I'll hand back over to Sonia.
Beautiful. Thank you so much. So thank you everyone for being a part of tonight's session. It's been an absolute pleasure to have you all. And thank you to Wendy and Chien, and also to all of the presenters that have been a part of our 5-part series with Banksia. It's been really great to work with you all, and I hope everyone's had some great learning opportunities in the palliative care space. By participating in tonight's event, which is RACGP accredited, you will receive 1 hour of educational activities, which I will lodge on your behalf. So that we can further improve our education workshops in the future, please provide us some feedback. You've got the QR code here to scan. You'll also get a link that comes up at the end of the webinar, and we will send you an email with that and other details as well. That email that we'll send you will be followed up within the next 4 weeks, and that will also have the presentation slides, the link to the webinar recording, as well as your certificate. And I think they're the main things for now. Thank you all again for your time and attention this evening, and we're so grateful that you've all come to learn a bit more about palliative care, and we hope you have a lovely evening. Thank you all so much. Bye for now.
Thank you.
Bye, Chien. Bye all.